Welcome iPix viewers. There's a dangerous myth that quietly permeates our healthcare system, our culture, and even our own minds. The idea that women are simply more emotional, more dramatic, or have a lower tolerance for pain. But what if the reality is far more disturbing? What if women are experiencing very real, often severe pain, and the system designed to help them is systematically failing to listen? I don't think people truly understand how often women's pain is dismissed, and I don't think people understand the profound, life-altering harm that this dismissal causes. It's a silent epidemic of suffering, where legitimate medical issues are brushed off as anxiety, stress, or all in her head. This isn't just about feelings being hurt. It's about delayed diagnoses, chronic conditions left to worsen, and lives being irrevocably damaged. Today, we're going to pull back the curtain on this medical gender gap. Let's change that. The data is staggering and undeniable. Multiple studies, including a landmark analysis from the University of Maryland, show that while women report more frequent and severe pain across a wide range of conditions, they are consistently treated less aggressively. They wait longer in emergency rooms for pain medication, are more likely to be given sedatives instead of analgesics, and are less likely to be believed when they describe their symptoms. This isn't a niche issue. It affects women of all ages, races, and backgrounds. A young woman with excruciating pelvic pain might be told it's just bad cramps for years before getting an endometriosis diagnosis. An older woman presenting with atypical heart attack symptoms, like fatigue and nausea instead of classic chest-clutching pain, might be sent home with antacids. A Black woman, facing the dual burden of gender and racial bias, is even more likely to have her pain underestimated and undertreated. A tragic reality confirmed by numerous studies on healthcare disparities. This phenomenon has a name: Yentl syndrome, coined by Dr. Bernadine Healy. It describes how women have to prove they are as sick as a man to be taken seriously. The evidence is clear. Women's pain is real, but it is not being treated as real. So, where does this deep-seated bias come from? The roots are tangled in centuries of medical history and cultural stereotypes. For generations, medicine was built around a default male model. Doctors, overwhelmingly male, leaned on stereotypes, viewing women through a lens of hysteria and emotional fragility. Pain in women was often psychologized, interpreted as a symptom of a troubled mind rather than a troubled body. This historical bias was cemented by a critical failure in modern science. For decades, clinical trials historically excluded women. Researchers feared that hormonal fluctuations would complicate study results, or they sought to avoid potential harm to women of childbearing age. While perhaps well-intentioned, the consequence was a catastrophic gap in knowledge. Medications, diagnostic criteria, and treatment protocols were developed based on male physiology. We learned how a heart attack presents in a 55-year-old man, but not necessarily in a 60-year-old woman. We understood disease progression in male bodies, leaving female-specific symptoms a mystery. This created a dangerous blind spot in the very foundation of medical practice. Even today, with more inclusive research policies, the legacy of this male-centric model persists in textbooks, in training, and in the unconscious biases that shape a doctor's split-second decisions in a busy clinic. The real-world impact of this bias is devastating. The result? Undertreatment is the most immediate consequence. A 2008 study found that women were 13 to 25% less likely than men to receive opioid pain medication in the emergency room for acute abdominal pain. This isn't just about discomfort. Inadequate pain management can hinder recovery, increase stress on the body, and lead to long-term complications. And then there are the delayed diagnoses. Conditions like endometriosis, an agonizing disease affecting 1 in 10 women, take an average of 7 to 10 years to diagnose. Years spent in debilitating pain, being told it's normal, being prescribed birth control or antidepressants as a catch-all solution, while the disease progresses internally. Autoimmune diseases, which disproportionately affect women, also face significant diagnostic delays. Patients are often shuffled between specialists, their wide-ranging symptoms of fatigue, joint pain, and cognitive fog dismissed as signs of depression or hypochondria. This delay allows irreversible damage to occur. The cost extends far beyond the clinic. There's the economic toll of lost wages from being too sick to work, and the mounting medical bills from a carousel of unhelpful appointments. There's the damage to relationships, as friends, family, and even partners struggle to understand a pain they can't see, and that doctors won't validate. And perhaps most insidiously, there is the psychological burden. When you are repeatedly told your reality is not real, you begin to doubt yourself. This medical gaslighting can lead to severe anxiety, depression, and a profound sense of isolation. But we are not powerless. Change is possible, and it starts with knowledge and action. For patients, the first step is to trust your own truth. Listen to your body. You are the world's leading expert on your own experience. Meticulously document your symptoms. Keep a detailed journal. What does the pain feel like? Sharp, dull, burning? When does it occur? What makes it better or worse? Rate it on a scale of 1 to 10. This data transforms a subjective complaint into objective evidence that is harder to dismiss. Be direct and assertive. Use firm language. Instead of, "It kind of hurts here," say, "I am experiencing severe stabbing pain in my lower right abdomen." Don't be afraid to ask questions. What are the possible causes of these symptoms? Why are you ruling out this condition? What is the next step? If you feel unheard, bring a trusted friend or family member as an advocate. And never ever hesitate to seek a second or even a third opinion. Finding a doctor who listens is not a luxury, it is a necessity. For clinicians and the healthcare system, the change must be systemic. It begins with education. Updating medical school curricula to include the latest research on sex and gender differences in disease presentation and pain perception. It requires a conscious effort to listen first and diagnose second, replacing reflexive skepticism with compassionate curiosity. We must also push for better research. This means continuing to mandate the inclusion of women and minorities in all stages of clinical trials and funding studies that specifically investigate conditions that predominantly affect women. We need better tools for pain assessment that go beyond a simple 1 to 10 scale and account for the complex, multidimensional nature of chronic pain. This is not about blaming individual doctors, most of whom are dedicated professionals working under immense pressure. It's about recognizing and dismantling a flawed system, a cultural inheritance of bias that harms both patients and the integrity of medicine itself. By raising our collective voice, by demanding more from our healthcare providers and researchers, and by empowering ourselves with knowledge, we can forge a new standard of care. A future where every patient, regardless of gender, is met with belief, empathy, and the diligent investigation their suffering warrants. Because pain deserves respect, not doubt.